So it was a pleasure and an honor to have Professor Gattinoni on this event, and we really take pride in inviting Dr. Gattinoni. Professor Luciano Gattinoni is currently a guest professor at the University of Göttingen, Germany. He is a world-renowned for inventing the extracorporeal CO2 removal technique in acute respiratory failure, promoting the baby lung model of lung injury as early as 1980s, and identified mechanical power variables to assess the risks of mechanical ventilation as recently as 2016. He has previously served as the president of the Italian National Society of Anesthesia and Intensive Care, the European Society of Intensive Care, and the World Federation of Societies of Intensive and Critical Care Medicine. His research focuses on the pathophysiology and treatment of acute respiratory failure, sepsis, and acid-based disorders. He has published more than 400 research articles in peer-reviewed journals. He is a honorary member of the German Society of Anesthesiology and Intensive Care. He is a fellow of and was awarded with a Lifetime Achievement Award by the American Society of Anesthesiology, the American Society of Critical Care Medicine, and the European Society of Intensive Care. So we are really honored to have Professor Gattinoni, and the platform is all yours. Professor Gattinoni, we welcome you, sir. Please decorate the stage, sir.
Good afternoon or good evening to everybody. At the moment I'm calling from speaking about in Milan for the vacation period. I had the occasion to hear the speaker before me, and I think I congratulate with the level of the speeches and the level of the concept. Now I try to convince maybe somebody of you about the importance of measuring lung volume, measuring pressure, in which condition, because to cure a patient, we have to understand the mechanism. To understand the mechanism, you have to measure. There are not protocol. There are not a guideline that can substitute for the observation and measurement. Let's first a very simple concept. The lung volume. Lung volume, the nomenclature is rather important because the lung volume, if it's measured at zero pressure, that means at atmospheric pressure, which is called a functional residual capacity, represent the resting volume of the lung. That means that the lung is in its natural condition. We use as a surrogate of FRC because the patients sometimes are quite severe. We use the lung volume measured at 5 centimeters of PEEP. But we have to specify the condition in which a measurement is made. I heard about this lung volume with at end expiration with PEEP. And you know, the end expiratory lung volume per se is just a definition. But the volume may be relatively small or maybe tremendous high. Depends on the condition of the lung and which kind of PEEP you put. If you put 20 of PEEP in a normal lung, you arrive almost close to the total lung capacity, to the physical limit of the lung. So it's extremely important to me to specify the condition of measurements. And let's see, this is a classical ARDS, and you see, this is the ventilable lung volume. That means most of the volume goes in these regions. Part may go also in new opened regions of the lung, but these are usually very small. And depends, when people speak about recruitment, in most of the cases, if you measure the recruitment with gases, this kind of recruitment represent a better inflation of units which are already open, are not opening of the new units. And this concept is not very well known. Now, let's see how is the lung made in, this is a normal lung, and you can see these are the CT numbers. Let's see, when you have minus 700, means you have 30% of tissue and 70% of gas. If you have 500 here, means 50% tissue and 50% gas. When you have here minus 100, 0, means gas 0. And this is exactly what's happening in RDS. You see most of the lung is out of business. Part is poorly aerated, and a small amount of lung is still open to the ventilation. But this, depending on the severity, may be, let's see, in an adult man of 70 kilos, may be 1.5 liters, 1 liter, 500 milliliters, 300 milliliters. You know, you have an extremely variable situation here, and you have to measure. This is an old kind of measurements. We start to use this kind of measurement since 30, 34 years. We were taking a balloon, we were filling the balloon with helium, and of course the helium is distributed into the lung. After 10, 15 inflation, you measure again the dilution of helium, and you can compute how much is the lung volume, the volume in which the helium has been diluted. Now we have automatic in the respirator, and you see, as an example, we have a quite accurate system of measurement. This study we did with Cumello several years ago. We were comparing the nitrogen dilution method with the CT scan, which is the gold standard. Of course, remember one thing, that when we measure with the dilution of gases, and I will show the nitrogen dilution, we measure the amount of lung, the volume of lung, which is reached by the ventilation. If I have a region of the lung which is completely hyperinflated and not ventilated, this is not measured by the nitrogen dilution or by helium dilution. Can be measured by the quantitative analysis of the CT scan. This is why the CT scan usually is a little bit higher, the values, than measured with helium dilution. I don't want to go in the details of the helium, of the nitrogen dilution, which can be done automatically by the ventilator. We start into the lung, we have a certain volume of the total lung, which is the end expiratory lung volume, is occupied by nitrogen. A certain volume is occupied by oxygen, and a certain volume is occupied by the VCO2. Of course, the total amount of nitrogen is the fraction times the volume in which this fraction is contained. Now, if I raise the oxygen concentration and I decrease the N2 concentration, I can measure the amount of N2 which has been expelled, which is equal to the differences of nitrogen fraction at the beginning, at the end, times the total volume, which is also equal to the FiO2 final minus the oxygen fraction initial. So I have my unknown is the end expiratory lung volume, which will be equal to the nitrogen which has been eliminated, divide the difference in fraction of oxygen between the final measurement and initial measurement. This takes a few minutes, but as I showed you before, the system is quite accurate. And the people doesn't like too much measure the things. And everybody wants to have a simple protocol, simple rule, simple equation. But the medicine is not very simple. You have the lung protective strategy. How fits this concept of lung volume and so on in lung protective strategy, which is not really not an easy concept of lung protective strategy, because if you look at the literature, a definition of lung protective strategy, okay, low tidal volume, 6 per kilos. What's about PEEP? Has to be included in the lung protective strategy? Probably yes, but how much of PEEP? Low PEEP, higher PEEP, intermediate PEEP. And remember, when in a literature we speak about higher or lower, means only one thing, that we do not the real answer. The real answer should be the number of PEEP, the number of centimeters of water that we applied. Anyway, the lung protective strategy basically, in my mind, means a treatment of the lung as gentle as possible. And you know, the ventilator or ventilation, but induced lung injury, because can happen also in spontaneous breathing, depends by interaction between the patient lung and the ventilatory setting. In spontaneous breathing, depends that this ventilatory setting is the power that our muscle put to ventilate. This interaction, okay, is not for one breath or two breaths, but maybe for hours or days. So the time is an extremely important concept. So if we want to understand something and to make our ventilation as gentle, as innocent as possible, we have to study the patient lung condition, and we have to study the ventilatory setting. And we have to know which are the interaction between the two. Now, let's start since the beginning. In 1967, Asbaugh and Petty say, okay, they look at 12 patients, part of them were treated with people, who had a different disease, a very different disease. But at the end of the story, they present with the same picture. And the picture was they had an edematous lung coming from different disease. When I put edema, the gas space is reduced, the lung volume, ventilable lung volume decreases. When this decreases, we have a series of symptoms, which are due to the pathology behind. Gas exchange, because edema formation causes collapse of the lung or non-functioning of some pulmonary unit. All the blood going there maintain is a venous composition, and I have hypoxemia. The lung becomes smaller, and again, when it gets smaller, the lung mechanics are affected. The compliance goes down. Remember, the compliance is not the lung which becomes stiff. It's the lung which becomes small. The compliance in one mouse or in one rat, perfect rat, healthy rat, is absolutely lower than compliance in an elephant. For one simple reason, the dimension of the rat lungs and the elephant lungs. And of course, if I have a small lung full of collapse, the poor heart, right heart, has to pump against this impedance, and we have hemodynamics. But all this depends by this primary mechanism, which originate from different disease. Remember that all our lung protective strategy, all these concepts derive from studies in which the patient had primarily pneumonia, bacterial pneumonia, or sepsis. We touch the COVID at the end, which is not in these two. It's a pneumonia, but it's not viral. It's not a bacteria, it's viral pneumonia. Anyway, this is the picture. And the common treatment which originates in patients with bacterial pneumonia and ARDS is to use the lung protective strategy, which may be summarized as low or lower tidal volume. Now, my dear colleagues, if 6 is better than 12, does not mean that 4 is better than 6, or 2 is better than 4, or 0 is better than 6. So low tidal volume is a philosophical concept. That means depends what we define low tidal volume and which patient, which are the patient condition, the patient lung condition. The same thing is higher PEEP. The lung protective strategy tell us that if you use a zip, maybe it's not a good idea, but doesn't tell us anything about how is the higher PEEP. Driving pressure. The driving pressure is an important concept, which is a sort of tidal volume normalized by the compliance. And then prone position, which I think is extremely important, not just for the increase of PO2, which happens not always, but in majority of the patient, about 80% of the patient do increase the PO2. But the prone position has a good potential to decrease the stress and the strain. So whatever force you put into the lung is distributed better if the patient is prone than if the patient is supine. Put in another way, whatever bad you do to the lung is less bad in prone than in supine position. And now back to the volumes, which are the relevant lung volume. We have the FRC. As I told you, this is the amount of resting lung. Okay, then I put the tidal volume as an example. If I have a zip, that means the PEEP is 0. And you saw these conditions are usually with P0 and so on. You say, well, we have a continuous maybe opening and closing of part of the lung. We have some arterial trauma. We are very far, usually, from the total lung capacity. Remember that if we have the FRC, which is equal to 1, the total lung capacity is equal to 2.53. That means compared to the FRC, the total lung capacity is between 2 and 3 times greater, which is quite important to know which are the limits of the battlefield, because all our ventilation goes from ear and ear. Let's see, I have a good idea to put the volume, the PEEP. And you know that the strain of the lung is how much is modified lung volume compared to FRC. So is tidal volume plus the volume due to PEEP. And this volume with a PEEP is greater than 10, 15, 20, may be enormous. And it's very easy at this point to reach the total lung capacity. At this point, our risk is no more the atherec trauma, is the volutrauma. If I do not know these volumes, how can I set logically the ventilator? You say, what is the problem? I have 6 milliliter per kilo. I have a normalization per kilo. Well, great. These are the corresponding pressure when we have a volume. Pressure and volume are two faces of the same medal. You ever remember what I present you is the stress and the strain, which are in somewhere to be normalized. Normalized for what? For the FRC. Let's see. Here is the stress and strain. This is the resting. I remind you, the resting volume is the volume at zip, and as I told you before, we use the volume at 5 of PEEP, which is not perfectly correct theoretically, but is safer when you measure the things. At this point, we put the tidal volume, or the PEEP volume, greater PEEP volume, and I create a distortion of the lung. The strain is how much is this delta compared to the resting. And to have this stress, I have to apply a force, which is a force over surface, which is the stress. Now, the stress is not really the force that I applied, but is the force which developed into the matrix of the lung, which opposes to the force applied, as in a Newton law. If I applied 10 centimeters of water inside the structure of the lung, all the fibers develop a counter force of 10 to oppose the force I applied. Because these are stress and strain. Now, the RDS lung is small. In normal, I have, let's see, FRC 2.5, 2 liters and a half, tidal volume 500, my strain is 0.2. And to move this 0.2, in normal lung, you use something at 2-3 centimeters of transpulmonary pressure. That means that the stress is 2-3 centimeters. Now, in RDS, if I use the same tidal volume, but the lung volume is small, the strain is 5 times greater, and the stress will be corresponding greater, because stress and strain goes together. And look at the tidal volume, because we have this dogma, 6 milliliters. 6 milliliters tell you that 6 is better than 12. But before the study, we had a series of studies in which we had patients treated, not in RDS net, we have 12 versus 12. We have 10 versus 7, 7 versus 11. We have different other tidal volume. I put here the slide with the pressures, but each pressure corresponds to the volume. This is just to say that in the same range, many other studies failed to show what we have shown with the RDS net at the extreme, 6 versus 12. If we would have done the study 6 versus 10, nobody would speak about lung protective strategy, maybe. because we know the 7 versus 8, 6 versus 9, we couldn't find any difference. Not only that, not significantly, but all the study, Brochard, Stewart, Brower, Amato, the treated group was here greater than the control group. So plateau pressure in 6 milliliters are not absolute values. Why? Because the lung weight, the lung volume during ARDS has nothing to do with the body weight. Look here. This is ideal body weight of 50, 60, 70, 80. And look here, this is the total gas volume. Now, if the gas volume normalized to the body weight, I should have a line going like this. Greater is the ideal body weight, greater is the gas volume. Not at all. You see, they follow more or less a line which is parallel. That means that this man with 50 or with 80 of ideal body weight, this patient had exactly the same total gas volume. And on this gas volume is measured the strain, not here. So we have the situation. We have the strain, tidal volume divided FRC, or if I use PEEP, remember, tidal volume plus PEEP volume divide the resting volume, which goes linearly, almost linear, not really linearly just in a brief space, is proportional anyway with the stress. And the constant of proportionality is called specific elastance. But look here as an example, strain versus tidal volume per kilo. Each outline is one patient. Let's see this patient, the yellow here. At 6 milliliters, the strain is 0.4. 0.4, I guarantee you, is absolutely innocent strain, not at all. Goes at 8, goes at 10, goes at 12, from 0.4 will go to 0.45 or 6. So in this, to F12 or F6, the strain, which is the real cause of VILI, it doesn't change too much. You have this patient. This patient at 6 had already a strain of 1.6, which become worse, increasing the tidal volume. And these are, each patient has his own strain when I apply 6 milliliter volume, going from 0.4 for 1.8. How can I believe in the tidal volume as a normalization during ARDS? I have to measure the gas volume of the lung. And here is the same reasoning with the pressure. Here in patient with airway pressure of 30, the mythical plateau of 30, no? You see in this patient the transpulmonary pressure was about 8, which is absolutely well tolerable. In this patient was around 27, 27. If I take an animal and I put 27 of transpulmonary pressure for 24 hours, in 24 hours I have a beautiful model of ARDS. The lung becomes tremendously edematous. So stress and strain goes together, and you can see when the strain is greater than 10, than 1, that means at each tidal volume we have the same amount of gas in as with the FRC. The transpulmonary pressure is around 12, which is probably quite dangerous. Now, what is the dangerous strain? You know, up to 1 surprisingly, also in men, this was an experimental study, is rather well tolerated. The lung is very resistant. The problem sometimes is very often the hemodynamics. The lung is resistant, but when we have a strain greater than 1.5, is a disaster. And you cannot know what is the strain of the patient if you do not measure it. Look here, these are peaks, and you see stress strain perfectly linear up to certain level. After that, we have a tremendous exponential increase and destruction of the lung. Now, what will be logically the point in which the stress strain become very dangerous? That is quite easy to understand. Depends but the physical construction of the lung. When my lung volume, I reach with the tidal volume plus the PEEP volume, a strain greater than 1.5, I enter in the regions of total lung capacity. Part of the matrix is already over the standard, like this. And I can arrive at straighter rupture. I have with some microfracture, then I have inflammation, then I have edema, and I have also have a macrostructure. And the specific lung elastance around 12 means when transpulmonary pressure is equal to 12, my strain is 1. If I measure simply this thing, I have an idea which are the limits of the battlefield on which I applied the mechanical ventilation. I heard somebody speaking about mechanical power. Mechanical power is not a great invention. Mechanical power is just a summary variables which include barotrauma, volutrauma, trauma, biotrauma. It's just all the possible harmful point of the mechanical ventilation, pressure, volume, flow, respiratory rate, important, PEEP, all are in one unit mechanical power. Remember that the mechanical power, of course, the mechanical power has to move the lung. To move the lung, I measure the energy. If the mechanical power is 0, the subject is dead. In an infant, I was pleased to see, in infant, the mechanical power, when the babies grow up, the mechanical power must get higher because the lungs are bigger. And that means I have to provide more energy. I have to provide a mechanical power greater in one rat or in one elephant. Once again, these are all capacity entity, so depend a lot from the size of the animal. And of course, it's just that I will spend time on this already. This is upper and complicated equation that just tell you how much is used to distend the lung of the energy, how much to move the gas, how much pressure to move to keep the lung open at that level of PEEP. Tidal volume times the pressure is nothing else than the total energy. Remember what is extremely important in the frequency. Because, this is in a single breath. This is the amount of the mechanical power which I put in. But this doesn't tell you about the frequency. But if I put a single energy, one breath of 3 per minute of 15 or 30 per minute, the mechanical power changes accordingly. I don't want to spend too much time here, but this just tells you that increasing PEEP for the same tidal volume, now the driving pressure, which is this color, orange, doesn't change too much, but the mechanical power went up tremendous. So be careful with PEEP, because PEEP, increasing PEEP greater than 10, 15, considering with extreme attention what you are doing in terms of hemodynamic and the mechanical power that you applied. You know? And you have perivascular edema, viral edema, well, okay. And we have vascular congestion, inflammation, and this when you increase PEEP. Now, what is nice with the mechanical power? This is a paper which has been very difficult to get published. I think we went up on anesthesiology, and we as a group of animals, and we gave the same mechanical power. But in some cases, the mechanical power was done using a lot of very high tidal volume. No? In this case, the tidal volume was something as 20 per kilo, and lower frequency and lower PEEP. In other cases, lower tidal volume, we increase the PEEP. In other cases, we increase the frequency instead of tidal volume and PEEP. And for the isomechanical power, we have the same lung weight and the same lung damage. So here, the mechanical power was induced by increasing tidal volume. Here, by increasing the frequency. Here, by increasing PEEP, but all reach this level, the same level, wet to dry and lung weight were exactly the same. That suggests, has to be confirmed in humans, but in animals is quite sure. And this suggests what is important is the total package of energy. And of course, the mechanical power, there are now more and more suggestions that greater is mechanical power is associated with the mortality. And remember, always, the VILI requires time, interaction of time. Here at the starting with we were using tremendous amount of tidal volume, and you start here with these lesions after 7 hours, then becomes this, and then become like this. There is one thing, that the lesion of VILI are recruitable. And when you speak about recruitables, it is extremely important to define the time of observation. And remember, everything, the VILI is strictly dependent on where the tidal volume is placed in the battlefield. Just a few slides on COVID. Well, look at the gas volume in COVID. These are the classical ARDS, bacteria pneumonia, sternum down to vertebra. The COVID, the same hypoxemia in these two patients, not two patients, these two groups of patients, 32 patients matched. They all had a PF around 100, so very severe ARDS, but the tidal volume, the gas volume was almost double. If we had a gas volume which is almost double, means that the risk of VILI are not so tremendous at the beginning. That means the compliance is good at the beginning. Then with time, the things may change. But in a patient with this tidal volume, at this stage of the disease, you use a high PEEP. You will overcome easily the total lung capacity. You may have a disaster. During the course of the disease, the gas volume may go down, and maybe the lung becomes more edematous. Not at the beginning. Look here. This is 95 of PO2 and 502. And this is the same patient, which was a friend of mine, who died because we didn't have space for admission. Look here, the CT scan was pretty normal. You know, this is not a baby lung, this is an adult lung. Here, is another bug. How can you say the COVID is recruitable, is not recruitable? Of course, depends on when you consider the patient. And to have the proper therapy, you have to measure. If you don't measure and look at the protocol, this is not medicine. A computer or a 5-year-old baby who knows how to read can do the job at the place of the physician. And we had terrible mistakes in COVID disease. The COVID, depending on intensive care, the mortality was between 10 to 90% for the same disease, not for the same syndrome, for the same disease, which is equal in Germany, in Italy, in India, in US, in Algeria. Wherever you were, you go, the disease is exactly the same. So to me, and I conclude, the important thing to do is measurements. Measure and measure. And fortunately, we have now the possibility with a modern ventilator to measure fundamental things as the tidal volume. I didn't speak about the oxygen consumption, the CO2 production, which is fundamental to arrange. We breathe to eliminate CO2. We cannot separate the thing and to have a standard. It depends at the case, at the temperature of the patient, at the stage of the disease. More we measure, more we understand, more we can take care of the patient. I thank you for the attention.
Very detailed presentation on the lung protection and the validation for the FRC to understand the parameters that is acting at the level of alveoli. Thank you very much for giving this detailed presentation. And I'll come to the audience. See, the chat window is open. If you have any questions, please put it in the chat window so that we can take it up with Professor Gattinoni. Gattinoni, I have one question which has come to us on regarding the mechanical power. So this is from Dr. Farhan. In the pediatric age group, as the age increases, the tidal volume increases and hence mechanical power also increases. When we divide the mechanical power with patient weight, this age-related confounding effect on volume is resolved. However, in children, as the age increases, the airway resistance reduces and the respiratory rate also reduces. In that case, how to take care of the fact of these two confounding factors while applying a concept of mechanical power in pediatric age group? How to determine the safe limits of mechanical power in children at different ages? Do we have any correction factor?
Well, of course, that's correct. You have to measure. As I told you before, the mechanical power is nothing else than the energy which is used to move the lung, and maybe sometimes insufficient, sometimes very often too much. Too much may induce a disaster into the lung. Why? When we introduce this concept, the basic reason for introducing was one, the frequency. Because the frequency, well, the people using 15 or 30 of frequency was used indifferently. Even in the ARMA trial, no? You have some patients who were treated with 30, 35 of frequency. At 30 of frequency, the mechanical power is twice as big as a 15. Okay?
Okay.
So with the mechanical power, give you an idea, is a summary variable that should open one smaller red light in your mind. and you say, oh my God, I have greater than 20 joules per minute, can be applied, can be introducing whatever ventilator, the mechanical power. Put it on the screen, because whatever ventilator has the possibility to measure this one. You see 20, say, oh, 20. Maybe it's too much. And you go to look the frequency, the tidal volume, and so on, and you understand what's going on. For the pediatric, I was pleased to see, it was very, very interesting to see how the mechanical power required to ventilate the babies increase with the age of the babies, because the baby grows up.
Yes, sir.
Yes, sir.
But the mechanical power per kg is not increasing, sir.
But hello?
Yes, sir. I was the one who was asking this question.
Yes, I know. I saw you.
So mechanical power was increasing, but when we divided by weight of the patient, so we are basically normalizing the mechanical power for weight. So that we are removing the confounding factor of tidal volume, but mechanical power per kg is actually falling after 10 years of age. I think that is because respiratory rate and airway resistance is falling after 10 years of age. Is it the reason?
Absolutely possible. You know, one the problem, the real normalization in adult is still very questionable. Should be done on the lung weight, on the gas volume, on the patient's volume, of the phase of the moon, and so on. You know,
Okay,
I don't have the truth in my pocket, no? I just tell you that when you have an excessive energy, and the frequency is still important, might be a disaster. I have a big fight with my friend Marcelito Amato, no? Driving pressure is not better or worse than mechanical power. Yeah. Driving pressure is part of the mechanical power.
Yes, sir.
Now they discovered that if you multiply the driving pressure for the frequency, is better to prognostic. Of course, is that driving pressure times the frequency is just the mechanical power. Nothing else.
Yes, sir. But in my study, sir, driving pressure is associated with mortality, but mechanical power is not coming to be associated with mortality. I don't know what is the reason. Maybe
well,
as the children are increasing in age, maybe that is the factor.
I don't know what to tell you, because there are the last paper review of about 2,000 patients was associated with the mechanical power and not the driving pressure. But I tell you, personally, I absolutely don't care about the outcome, the prognosis. Everybody died at the end, including the doctors. What is important to me is to understand the mechanism.
Yes, sir.
And to me, the mechanical power is just a way to call the attention on some variables that before was completely ignored. Yes. We had only the tidal volume and the plateau pressure, right?
Yes, sir. True, sir.
No we didn't know what kind of pit to use. We didn't know in which are the limits on which our mechanical ventilation might be dangerous. I mean, of course, if I have an FRC small, I multiply it by 3, 2.5, and 3, I know these are the physical limits of my lung. And you don't need to be Einstein to understand that if you push with a hammer 20 times or 30 times per minute for one day, it's not a good thing to do in an inflamed lung.
True, sir. True, sir.
I don't need 2 million of patients on a randomized study of millions of dollars to understand that.
Yes, sir. So we need only prospective studies to find out cutoff value. What is normal, what is abnormal for children, we don't know.
That's right. You know that you have already a quite important contribution in this age. I don't know if it continues going up until the adolescence, but what I can expect, that to move the lung on an older man, you have maybe to put more energy than to move the lung on a young athletic man coming back from the Olympics, or launching you won the launch of the gold medal of India, right? Was launching, how do you call it? We call giavellotto in Italian, when you Lance.
Yes, sir. True, sir.
Thank you,
Anyway,
thank you, thank you, Professor.
Thank you, sir.
Gattinoni.
Thank you so much, sir.
That was very insightful, sir, and it was such a detailed and elaborate. And thank you very much for taking your time out on a Saturday to come on board and give us and share your knowledge with the audience of Asia. And as you know that today we have on the call we have the clinicians and participants from India, Bangladesh, Nepal, and Sri Lanka.
Okay, my best wishes and my best hello to everybody. Okay, in our difficult world. Okay, good. Have a good time.
Thank you very much, sir. Thank you.
Bye bye.
So
Bye
thank
bye.
you, and thank you for all the participants. And now I invite Harindra Kotian, who is our product manager for Northern West. Hari, we welcome you to give the and address the session, and with the ending note, please.
Thank you, Prabhu. Thank you. And I can't see a better, knowledge shared at this kind of a platform. Dr. Gattinoni's presentation was awfully the best, I would say. Thank you, all the panelists also. You have taken out time for this, for quite, and shared your presentations and your views, your experiences. That's really going to help us around. And I'm sure the points discussed over here is of a lot of value for implementation in the ICU for the audience. I also thank all the audience who had taken time to participate and get the in-depth of ICU, takeaways, critical takeaways. So we are actually extremely proud to launch our flagship product, R860 V11. R860 is already there and made ripples around with the in the premium segment. We are taking it to the next level with the clinical decision-making tools and the HFOT. Now, all these tools are actionable in ICU for sure. And, like Dr. Gattinoni was saying, every, you observe, implement, and measure, So these are things that we can easily do with this higher-end tools. I request you to get used to this. If there are any questions, or any feedbacks or any demo requests, please get in touch with our regional teams. This would be, attended to, and we will give you a lot of data for implementing these tools. Finally, I'm extremely also thankful to the South Asia leadership team and the regional teams who had made this such a wonderful product and launching this dependable technology in India. Thank you very much for joining. Before we close today, there is an upcoming launch on anesthesia carestation in September. We'll just have a glimpse of this. Paul, is there Thank you, everybody. And that will be all from us today. And have a nice weekend.